Hello, my name is Salvador Escorza, and I am from Mexico City at Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán. And I'm going to talk about a intrahepatic cholangiocarcinoma associated with hypercalcemia secondary to 125 dehydroxyvitamin D in a young adult. So we have the case of a 31-year-old male without relevant past history who presented with severe hypercalcemia and weight loss. A CT scan revealed an abnormal mass in the hepatic segments 5 and 6. We took laboratory tests which showed normal AFP, CEA, and CA19-9, but he had elevated serum calcium at 1448, a low 25 hydroxyvitamin D at 12.1, and an abnormally high 125 dehydroxyvitamin D at 80.6. Further testing revealed low PDH at 0.9 and a normal PDH RP, which was lower than the standard. And we took an FDG PET CT scan, which showed a hypermetabolic 15 centimeter solid mass, which involved the hepatic segments at 4, 5, and 6, and segment 8. There were no distant lesions. We took a liver biopsy, which concluded cholangiocellular carcinoma, which is a subtype of biliary tract carcinoma, which was positive for CK7, CK19, and CK18, and was negative for arginase 1, HEPAR1, and glypican-3. A comprehensive genomic profiling matched this tumor to a cholangiocarcinoma with a pathogenic variant for IDH1. A diagnosis of unresectable intrahepatic cholangiocarcinoma was concluded. So we started chemotherapy with this patient with gemcitabine, cisplatin, and nab-paclitaxel. After 5 cycles, we achieved stable disease. So to increase response and conversion rate, a surgical hepatic arterial infusion pump was placed, and he was started with HAI chemotherapy with continuous infusion of fluoxuridine over 14 days and systemic gemcitabine oxaliplatin every 2 weeks. After 8 weeks of treatment, a CT scan showed partial response. And after taking some laboratory tests, we demonstrated that the calcium and 125 dehydroxyvitamin D levels were within normal range. And right now the patient continues in treatment. So cholangiocarcinoma is a heterogeneous disease and is rare in young adults, making the diagnosis difficult. Malignant hypercalcemia is an unusual finding at the diagnosis of this disease. In solid organ malignancies, MH is frequently characterized by elevated parathyroid hormone-related peptide and squamous cell histology. If the PTH-related peptide is normal, other mechanisms should be suspected, and 125 dehydroxyvitamin D should be assessed. In those cases, with 125 dehydroxyvitamin D is elevated, the proposed mechanism of MH is the overexpression of CYP27B1 in tumor cells. This type of hypercalcemia secondary to 125 dehydroxyvitamin D is more common in hematologic malignancies. In solid organ malignancies, it is extremely rare. There are only 17 cases reported. In general, the prognosis of patients with malignant hypercalcemia is poor due to the advanced stage of the disease. So in conclusion, we presented a case of unresectable cholangiocarcinoma with hypercalcemia as an initial manifestation. Increased serum calcium levels, low PTH, and normal PTH-related peptide levels should aware physicians to assess 25 hydroxyvitamin D and 125 dehydroxyvitamin D levels. MH secondary to 125 dehydroxyvitamin D is extremely rare in solid organ malignancies. Finally, multimodal treatment could improve oncological outcomes in this type of diseases. Thank you very much.